Good morning. Welcome back to Open Med School. Today I am going to discuss with you an overview of acute kidney injury. What is acute kidney injury and why this term acute renal failure is replaced by acute kidney injury? This is what we are going to discuss. So, what is acute kidney injury? There are different criteria and classifications. The earlier one was the rifle criteria. Rifle stands for risk, injury, failure, loss, and end stage. But now it is found that even without development of renal failure, some injury occurring to the kidney can have significant effect on morbidity and mortality. That is why this rifle criteria is later changed to akin, and now we follow is the KIDIGO definition. KIDIGO stands for kidney disease improving global outcome. It has only three simple things. First and foremost is the urine output. It is simple, easy to measure, is possible everywhere. Urine output less than 0.5 ml per kilogram for 6 hours. We can say patient has developed a kidney injury. Again, remember it is not the absolute value, it is 0.5 ml per kilogram. For example, somebody is 50 kilogram, 25 into 0.5 will be 25 ml into 6 hours, that is 130 ml. In case of a 100 kilogram person, this amount will be 100 into 0.5 will be 50 into 6 hours is 300 ml. So remember, it is, you should not look into the value, but you should look into 0.5 ml per kilogram per hour. So this is the earliest evidence even when creatinine has gone up. And again remember, sometimes urine output can be normal in kidney injury. So that is why you should look for the serum creatinine. Serum creatinine rise 0.3 milligram per deciliter, that has occurred over the last 48 hours. I already said that is a sudden decline in renal function occurring over hours to days. We can take the patient has got a acute kidney injury. Second criteria you can use is the increase in serum creatinine 1.5 times from the baseline, which has occurred over the last 7 days. So somebody has got a 2 milligram creatinine as a baseline value. If it has been 2.5, you can say that patient has developed a acute kidney injury. Hope this definition is clear. This is what I have told you. What is adequate urine output? For a 60 kilogram person, it is 30 ml per hour. For a 100 kilogram person, it will be 50 ml per hour. Check this point. The morbidity and mortality from acute kidney injury ranges depending upon the severity. It can change up to 80% in certain situations. Usually it's 30 to 40%. So keep in mind, it has got a significant morbidity and mortality. So now we should think about what are the risk factors for acute kidney injury. One is age. Anybody up the age of 65 is at risk. People with diabetes mellitus, hypertension, they are at risk. Especially when they undergo a major surgery, they develop hypotension, develop sepsis, undergo contrast scans, and various medications. All these increases the risk for acute kidney injury. A pre-existing acute kidney injury or a previous history of AKI or patient with a already having a chronic kidney disease, they are also at a high risk of developing acute kidney injury. So what are the types of acute kidney injury? It's a traditional classification you divide into pre-renal, that is before the kidney, that is mainly it is the volume or perfusion occurring with the kidney. Renal, that is the intrinsic renal problems. Post-renal, that is the obstructive uropathy. So, hope you understood the classification, the basic types of renal injury. Now we go into the symptomatology. Signs and symptoms of acute kidney injury depends upon the situation in which AKI has occurred. If it is with hypovolemia, there will be evidence of dehydration. In addition, there will be reduced urine output, difference in the change in the color of the urine will be there. But in the setting of a patient, somebody has got a heart failure, overhydrated, they develop a renal failure. Due to decreased perfusion, you may not get evidence of dehydration. This point to be kept in mind. The symptoms produced to rise in blood urea and creatinine or blood urea nitrogen is called uremia or uremic symptoms. So a patient can develop they are usually gastrointestinal or neurological, nausea, vomiting, vague abdominal discomfort, and altered sensorium, and even seizures can occur. These are the symptoms, and many times patient can be asymptomatic at the time of acute kidney injury. That is why laboratory testing is relevant. How can you prevent? First, identify who are at risk. Second is improve the management of fluid, because hypovolemia is a number pre-renal cause is the, and second major cause is drugs, NSAIDs, ACE inhibitor, ARB. So identify the risk factor, then recognize early recognition of the deteriorating patients. Anybody in the ICU, anybody admitted with shock, anybody with the burns, anybody with snake bite, all at risk of AKI. We can use the mnemonic SHOUT. Screen for sepsis. Yes. Assess the hypovolemia. Assess and document the fluid status. O stands for the obstruction. Ultrasound scan. And mandatory. You test the urine, look at the color of the urine, analyze the urine, and stop or change high risk medication, that is SHOUT. So remember, this T stands for the toxins, S stands for sepsis, S for hypovolemia, O for obstruction, U for urine analysis, and T for toxin. We have already said about the medications. The high risk medications are ACE inhibitors, angiotensin receptor blockers like losartan, sometimes NSAIDs, diuretics, aminoglycoside. Beware of medicines that may be harmful to your patient and may make them feel worse when they are already unwell. So, a patient with sepsis with acute kidney injury started on gentamicin. They can worsen acute kidney injury. Why in the era of sophisticated investigations you should check the urine? The earlier we spot and treat AKI, the more chance we have to from preventing it progressing. And the urine testing is simple, non-invasive, easy to perform, and available everywhere. Early signs of kidney damage include proteinuria, small amounts of RBCs in the urine, especially in cases of intrinsic renal disease. Measuring the urine output is also fundamental because it is a criteria for diagnosing AKI. The color of urine is important. So, when the color changes from yellow to brown, suspect dehydration. So, simple checking of the color of urine. The importance of fluid balance has to be stressed. Monitor fluid balance daily basis and cumulative basis. daily weight is a good indicator of fluid balance rather than looking only at the fluid chart, because 24-hour urine collection, unless the patient is on catheter, etc., will be difficult. So make it a point to take the weight of the patient. Accurately record fluid input and output. Every day look at it. So in summary, prevention, early identification, and early management are key for prevention of AKI. This will reduce the mortality, length of stay, and improve patient outcomes. In the next session, we will discuss with the different types of renal injury, that is pre-renal, renal, and post-renal, and how to diagnose it. This is an overview. Thank you.